Hello, I'm Alice Theodem, and I'm going to be discussing the chapter on the epidemiology of traumatic brain injury, also known as TBI, written by myself, Valerie Fagan, Florence Reith, and Andrew Mars. This presentation aims to describe traumatic brain injuries and how they are classified. It will also review the existing evidence of the incidence and prevalence of TBI across the globe. We will explore differences in epidemiology, both in terms of geographical location as well as over time, and to identify people who are at the highest risk of injury. Evidence of outcomes across the severity spectrum will also be briefly discussed, including mortality. The limitations of current evidence based on our understanding of the epidemiology of TBI will also be considered. Traumatic brain injury is a significant public health problem globally. It's often referred to as a silent epidemic, as symptoms are invisible and society is largely unaware of the high frequency of the problem and its potential short and long-term consequences. The financial burden of TBI is estimated at $86 billion per year in the US alone. TBI is sustained when there is an external impact causing injury to the brain, resulting in an altered level of consciousness. TBIs can be sustained through road traffic incidents, falls, violence, sport, or just during everyday activities. Over 80% of TBIs occur in low to middle income countries and are mainly caused by road traffic incidents. In high income countries, the epidemiology of TBI is changing, and falls are now the major cause of TBI, with an increasing incidence in the elderly. Most people have mild injuries, but residual effects that can affect a person's ability to function in everyday life are common. Ongoing effects can include headaches, fatigue, noise sensitivity, cognitive impairments, and visual disturbances. Of concern is that evidence suggests that the burden of TBI is increasing globally. TBI affects all societies around the world, and it has been estimated that nearly 1 in 2 people across the globe will have at least one TBI in their lifetime. It's important to note that TBIs are largely preventable, particularly in terms of re-injury. The exact definition of what a TBI is and how to classify severity most effectively remains a matter of debate. For example, the term head injury is often substituted for TBI, but it is broader because it can include injuries to the face and scalp without underlying brain trauma. In addition, sports concussion is often researched in isolation, but it is a mild form of TBI. In trauma centres, scoring systems are frequently applied to classify the severity of injury, as shown here in the table. TBI severity is often categorised by level of consciousness, as assessed by the Glasgow Coma Scale score. This assesses eye, motor and verbal reactivity, and yields separate scale scores as well as a total score between 3 and 15. Higher scores indicate less severe injury. Both the scales and total scores are useful. The scales are especially useful in daily clinical and follow-up of TBI patients, and the total score is used mainly for research purposes. The motor component provides more discrimination in patients with severe injuries, whereas the eye and verbal scales are more discriminative in patients with moderate and mild injuries. When classifying severity, it is important for clinicians to be aware of any alcohol or substance use, sedation, paralysis, or intubation, which can all affect the scores. It is also important to be aware that the Glasgow Coma Scale does not tell us much about the underlying pathology, or the risk of unexpected deterioration resulting from bleeding or swelling in the brain. It is also useful to categorise the severity of extracranial injuries, as TBI often occurs alongside other injuries such as fractures or abdominal injuries in more than a third of cases. These injuries can be assessed using the abbreviated injury score, or injury severity score as shown in the table here. Structural brain damage can be assessed by CT or MRI. Various scoring systems exist, of which the Marshall CT classification is used most frequently. The prevalence of TBI is a measure of the total number of people living with the effects of TBI at a given point in time, which is known as point prevalence, or in a given period, known as period prevalence. This includes existing as well as new cases. Prevalence can be expressed as the number of living people with TBI per 1,000, 100,000 or million persons, or as a percentage. The Global Burden of Disease study has reported that 759 per 100,000 people are living with sequelae following TBI. However, this figure is based on modelled estimates. This is because there are few high-quality, longitudinal studies with long-term follow-ups across the TBI severity spectrum. With some studies showing up to 750 per 100,000 cases of new TBI occurring each year, and nearly half of these experiencing ongoing difficulties, current prevalence figures are likely to be a substantial underestimate. There is evidence that the global prevalence has increased by 8.4% between 1990 and 2016, although it's unclear if this is due to an actual increase or better data capture. Incidence is the risk of new TBI cases within a specific period of time, also presented as a rate per 100 or 100,000 or million. The Global Burden of Disease study projects that global incidence of TBI is 365 per 100,000. As you can see in this figure here, incidence of TBI differs considerably by country. The highest incidence of TBI has been observed in Central Europe, Eastern Europe and Central Asia. One of the most notable differences in TBI incidence is the rate of hospital admissions between Europe and the US. Adjusting for population structure, the EU has 3 times the hospital admission rate of the US. There are also large variations of TBI incidence within countries. For example, studies in Australia have showed different incidence rates across the country. Evidence is also inconsistent about whether there is a higher incidence in rural or urban areas. Given the lack of standardisation of the definition of TBI and classification discussed earlier, differences in TBI incidence are likely to be due to varying definitions of injury, inclusion criteria and sampling. Standardisation is needed to give us an accurate global picture of the burden of TBI and to enable us to determine differences due to methodological issues and actual true differences. Children under 5 years of age and older adults over 65 years of age are at highest risk of TBI. As you can see in the table, which presents data on studies conducted over a 35-year period from 1984 to 2019, the median age and percentage of people aged over 50 years is rapidly increasing. This may be due to traffic safety laws and preventative measures that have reduced the incidence of TBI from traffic incidents occurring primarily in younger patients. It may also reflect increasing age of the population. A complicating factor in the management of TBI in elderly patients is the extensive use of anticoagulants. These increase the risk for intracranial hemorrhage. Other populations at high risk of TBI include those in the military, prison victims of domestic abuse, as well as ethnic minority groups. Mortality rate is a measure of the number of deaths in a given population, taking into account the size of that population per unit of time, usually 1 year. Case fatality rate represents the number of deaths from TBI in relation to the number of patients with TBI, and this is expressed as a proportion or percentage. Both mortality rate and case fatality rates are often used as measures to express the severity and outcomes of injury. However, rates and proportions are significantly influenced by baseline patient characteristics, such as comorbid conditions, age, as well as diagnostic criteria used and completeness of case ascertainment. Comparisons between different hospitals can be complicated by differences between patient populations and selection bias. For example, those hospitals treating the most severely injured patients have higher case fatality rates. Because of the variability in data collection and the lack of standardisation, comparison of mortality rates between different studies is virtually impossible. As you can see in the graph here, age standardised mortality rates range between 11.7 and 17.9 per 100,000. This data only reflects mortality in high-income countries, as there are no age standardised data available in low to middle income countries to date. TBI mortality does appear to be increasing. For example, a 10% decrease in TBI-related deaths has been shown in the United States between 1997 and 2007. This is likely to be the result of combined effects of prevention, improvements in emergency medical systems, trauma organisation, and the implementation of guidelines. However, in patients older than 75 years, a significant increase in TBI-related deaths has been found. There is a clear need for developing a system for calculating standardised mortality rates in the field of TBI, adjusting for baseline characteristics available on admission using prognostic models. Approaches to TBI prevention and management of TBI in older adults needs to change as the population ages and as insight into the disease entity of TBI increases. Among people who have sustained a TBI, there is a 7-fold increase in mortality risk. Ongoing efforts to quantify the magnitude of the problem posed by TBI are limited by many factors. Differences in the inclusion criteria and lack of standardisation consequently create variation in results from epidemiological studies and makes comparison between studies highly problematic. Additionally, many mild brain injury patients often refrain from seeking medical treatment. This may be due to a lack of awareness, not wishing to miss a sports match, or due to concerns there may be a risk of incurring criminal charges. Studies relying solely on hospital statistics accurately and reliably record the number of admitted patients, but do not always account for pre-hospital fatalities or general practitioner-treated TBIs. This leads to an underreporting in incidents. Different combinations of ICD codes have also been used across epidemiological studies. Some studies only include code S06 for intracranial injury, whereas others have also included S02, which is fracture of the skull, and S07, a crushing injury of the head, and S09, other and unspecified injuries of the head, affecting incidence and prevalence reported. Most studies have been conducted in high-income countries, and studies are urgently needed in low to middle-income countries to enable a more accurate estimate to be provided. We eagerly await the results of a few studies currently underway. Further incidence and prevalence do not always capture recurrence, and particularly prior occurrence of injury, which is hard for patients to recall, and for which there is often poor recording in the medical notes. This is important as there is evidence of a cumulative effect from re-injury, which can increase the burden from TBI. To conclude, TBI is a significant global issue that is increasing. The current evidence reveals that infants and young adults, ethnic minorities, sports, military and domestic violence populations are at particular risk. There is evidence of regional variation in incidence and prevalence, but whether these are true reflections of injury burden or just a reflection of methodological differences remains unclear. There is an urgent need for standardisation of epidemiological studies in this area to increase our understanding of the epidemiology of TBI. Thank you.